In this section, we'll look at the different ranges of motion, axes of rotation, and classes of synovial joints. After that, we'll look at the names for the different motions or movements we see in synovial joints. The range of motion of a joint are the degrees through which that joint can move, and it's used as one aspect of physical assessment in a patient. We could otherwise call it flexibility. The range of motion is determined by the structure of the articular surfaces. In many cases, the joint movement is limited by the shapes of the bone surfaces. For example, you can't straighten your elbow beyond 180 degrees because the olecranon of the ulnar fits into the olecranon fossa of the humerus and prevents any further movement. The range of motion is also determined by the strength and tautness of ligaments and joint capsules. Some bone surfaces impose little, if any, limitation on joint movement. The articulation of the phalanges are an example. As one can see by examining a dry skeleton, an interphalangeal joint can bend through a broad arc. In life, however, these bones are joined by ligaments that limit their movement. As you flex one of your knuckles, ligaments in the anterior palmar side of your hand go slack, but ligaments on the posterior dorsal side become tight. Double-jointed people have long and slack ligaments that allow a lot more movement in that joint. In addition, the range of motion is determined by the action of the muscles and tendons. For example, extension of the knee is limited by the tension in the hamstring muscles. So in many joints, muscles oppose each other and moderate the speed and range of joint motion. Even a resting muscle maintains a state of tension called muscle tone, which serves in many cases to stabilize the joint. The nervous system is continually monitoring and adjusting joint angles and muscle tone to maintain joint stability and limit unwanted movements. When we think about geometry, we recognize three perpendicular axes, the X, Y, and Z axes. In anatomy, these correspond to transverse, frontal, and sagittal planes. So just as we can describe any point in space by its X, Y, Z coordinates, we can describe joint movements by reference to these three anatomical planes. A moving bone has a relatively stationary axis of rotation that passes through the bone in a direction perpendicular to that plane of movement. A multi-axial joint, like the shoulder joint, has 3 degrees of freedom or 3 axes of rotation. Most other joints are either going to be monaxial or biaxial. These are important things to consider as we discuss the different possible movements of synovial joints coming up. There are several different classes of synovial joint. We're going to look at ball and socket joints like the shoulder joint, pivot joint like the radius, pivoting on the humerus, saddle joints as we see in the carpal bones, hinge joints like we see in the elbow, planar joints like we see in the movements between some carpal bones, and then condylar joints that we can see in our metacarpal phalangeal joints. So ball and socket joints have 3 axes of rotation. Their smooth hemispherical head fits within a cup-like socket. The 2 joints that we have in our body that fit ball and socket are the shoulder joint and the hip joint. In the shoulder joint, we see the head of the humerus fit into the glenoid cavity of the scapula. It's held in place also by the acromion process and the coracoid process. In our hip joint, the head of the femur fits into the acetabulum of the hip bone. These are the only multi-axial joints in our body. Condyloid or ellipsoid joints are the ones like we see in our metacarpal phalangeal joints. Their oval convex surface of one bone fits into the complementary shaped depression on the other. We also see this in the radiocarpal joint in the wrist. These are biaxial joints, so they allow movement in two different planes. Saddle joints, as we see in some of the metacarpal bones, have both bones having an articular surface that's shaped like a saddle. So one saddle onto another saddle, you can see here. They're concave in one direction and convex in the other. The trapezio-metacarpal joint at the base of the thumb is a great example. And then also the sternoclavicular joint, where the clavicle articulates with the sternum. These are also a biaxial joint. They're a little bit more movable than the condyloid or hinge joint, though. This is the joint that allowed the formation of the opposable thumb that's so characteristic of primates. Plane joints or gliding joints involve flat articular surfaces in which bones slide over each other with relatively limited movement. They're usually a biaxial joint. These are like the carpal bones of our wrist and the tarsal bones in our ankle, and also the articular processes of each of our vertebrae. Here's a good question, speaking of vertebrae, that I ran into the other day. How many articular surfaces are on each thoracic vertebrae? And can you name them all? Pause here for a minute and think about that. There are 10. See if you can figure them all out. Hinge joints are joints with a convex surface that fits into a concave depression on the other bone. This is an example of the hinge joint. At the elbow joint, the ulnar and humerus interact. In the knee joint, the femur and tibia interact. And then in the finger and toe joints, we see hinges. They're monoaxial joints. They move freely, but only in one plane. Finally, pivot joints. This is where one bone has a projection that's held in place by a ring-like ligament. The bone spins on its longitudinal axis. Now, we've looked at one of those in quite some detail, the atlantoaxial joint between cervical vertebrae 1 and 2. The dens of the axis is a projection that goes up into the atlas. It's held in place by a transverse ligament, and it allows pivoting of the head in the no direction. The proximal radio-ulnar joint also allows the radius to rotate during pronation and supination, and it's held in place by the annular ligament. These are also monoaxial joints. Take a moment here to write down all the different types of joints, draw a quick diagram of each, and come up with an example of each. So now it's time to look at the different movements that are possible in synovial joints and the names of those movements. This terminology is used in kinesiology, physical therapy, and many other medical fields. They may be presented in pairs with opposite or contrasting meanings. And we need to understand the anatomical planes and directional terms. So if you're rusty on those, go back to chapter 1 and review them quickly. Remember, the zero position is the position of the joint when the person is standing in the standard anatomical position. That is, facing forward with the palms facing forward. Joint movements are described as deviations from the zero positions and then the return to that zero position. Let's first look at flexion, extension, and hyperextension. When we flex our biceps, as you see in this top picture, the angle is decreased between the forearm and the humerus. So flexion is a movement that decreases a joint angle, and it's very common in hinge joints. Extension is the opposite of that. It's where we increase the angle between two bones and return the body part to the zero position. Hyperextension is going further than a regular extension to a point that's beyond the zero position. So flexion and extension can happen at nearly all diarthroses. Hyperextension, however, is limited to only a few. We can hyperextend our spine by leaning our upper body backwards. Some people can hyperextend in the knee joint and the elbow joint a little bit. Other people cannot. You can see an example of flexion, extension, and hyperextension in this lower picture when we consider the wrist joint. We're extended at 0 position and then flexed as we decrease the angle between the fingers and the wrist. And we're hyperextended when we bring them back beyond that anatomical 0 position. Again, we can look at that in the arm. We can flex the whole arm up to shoulder height. We can extend it back to 0 position. And then we can hyperextend, going back behind our back. We can also do hip flexion and extension and knee flexion extension, as well as ankle flexion and extension. In abduction and adduction, we're moving a body part away from the body or back towards the body. So adduction is the movement of a body part in the frontal plane away from the midline of the body. An example of hyperadduction would be when you stand with your ankles crossed. And hyperabduction would be if you raised your arms high enough to cross slightly over the front or back of your head. I think of abduction as aliens would abduct you away, and adduction is adding back to the body. In elevation and depression, we're seeing raising and lowering of a body part. When we shrug our shoulders, we elevate and depress. Protraction and retraction is where we move a body part in the transverse or horizontal plane. Retracting our shoulders is to roll them back, and to protract our shoulders would be to hunch our back and roll them forward. Circumduction is where we go through a sequence of flexion, abduction, extension, and adduction. It's basically a circular movement where one end of the appendage remains stationary while the other makes a circular motion. Rotation is a movement in which a bone spins in its longitudinal axis. We can rotate our trunk, we can rotate our head, we can rotate our thigh, or we can rotate our arm. We can have medial rotation, in which the rotation turns the bone inwards. We can have lateral or external rotation as we turn the bone outwards. Supination and pronation are primarily forearm movements or leg movements. Supination is where we turn the palms to face anteriorly or upwards. So supination is to roll the thumbs outwards. In the feet, it looks the same. Supination is where the feet roll out onto their outer edges. In pronation, we see the opposite. In the forearm, it's movement where we turn the thumb inwards, so the palm faces posteriorly or downwards. In supination and pronation in the forearm, we see the radius, which is on the thumb side, crossing the stationary ulnar. We can see pronation in the feet when we roll onto the inner arches of the foot and the feet flatten. Many different running shoes are made for either supinating feet or pronating feet. Pronation is a little bit more common. Again, reviewing flexion, extension, and hyperextension, we can see that each is possible in movement of the trunk. We can also have lateral flexion, curve the vertebral column towards one side or the other. We can see rotation in the trunk and the head. We can have a right and left rotation of either the trunk or the head. Now the mandible has some special movements of its own. Lateral excursion, which is right or left movement from the 0 position. Medial excursion, which is movement back to the medium or 0 position. We see this in side-to-side grinding during chewing, lateral excursion and medial excursion. We can also see protraction and retraction, where we extend the chin forward and pull it back, and elevation and depression as we open and close the mouth. The hands and fingers also have a few special movements of their own. We can see ulnar flexion, which is where we tilt the hand towards the little finger, radial flexion, where we tilt the hand towards the thumb, flexion of the fingers by curling them, extension of the fingers by straightening them again, abduction as we spread them apart, adduction as we pull them back together. So we can have flexion of the thumb, where the tip of the thumb is directed towards the palm. And we can have extension of the thumb, where we straighten it. We can have radial adduction, where we move the thumb away from the index finger. And we can have palmar abduction, which is moving the thumb away from the hand and pointing it anteriorly. We can have adduction of the thumb, moving it back to zero position. And then we have the feature that we're so well known for, opposition. This is where we move the thumb to touch the tips of any of the fingers. And repositioning is returning the thumb to the zero position. There are also some special movements in the foot. Dorsiflexion and plantar flexion. Dorsiflexion is where we elevate the toes as you do while swinging the foot forward, taking the step for your heel strike. Plantar flexion is where we have extension of the foot, so the toes point downwards, as in when we stand on tiptoe or point in a ballet shoe. We have inversion and eversion. Inversion is where the soles of the feet turn medially, and eversion is a movement where the soles are turned laterally. So very similar to pronation and supination. However, this would be if your feet were unweighted. Supination is a complex combination of plantar flexion, inversion, and abduction, while pronation is a combination of dorsiflexion, eversion, and abduction. So they're slightly different in their movement also as a result of bearing weight. So that's a whole lot of terminology, and we have an assignment to get this terminology straight. The assignment involves producing a paragraph about movements. You could teach me to do the Macarena, or you could teach me to ski, or you could teach me to play basketball. In this paragraph, and maybe a half page or so, you're going to insert as many of these movement terms as possible. Each one will be worth a quarter point to a maximum of 5 points. This is the first of our steps in presenting to the class. It's really brief. You'll get up, you'll demonstrate your sequence of movements while telling us what you're doing. I prefer that you don't read from your sheet of paper as you present, but totally understand if you need to, just for this presentation. So get to work on that. See how many words that you can put into a sentence together and build a short paragraph and teach the whole class how to perform something that you like doing. Make it light, entertain us a little. So the remainder of this chapter addresses the anatomy of selected diarthroses, which brings us to the point of our assignment for this chapter. In addition to this brief movement paragraph, you're going to do a joint feature. The assignment itself is listed under the contents of this chapter. But basically, you're going to feature a joint. As I had said early in the lecture, pick a joint that you've had an injury to or a family member has had an injury to that you'd like to learn more about. You'll highlight that joint in its normal condition, addressing its joint capsule and any ligaments and tendons that might be involved. And then you'll tell us about the injury. What happens with the injury? What goes wrong? Which pieces get broken? And then how is that injury most commonly fixed? Be sure to both describe and show us figures of how it all works.